Good evening, everyone, and welcome to this online webinar, Online Cancer Diagnosis and Treatment. Today, it's my pleasure to introduce you to Dr. Tanya Kufer, medical oncologist and professor of oncology at the medical faculty of the University of Ljubljana in Slovenia, and also researched at the EOTC group on breast and lung cancer. Dr. Kufer, on behalf of Lung Cancer Europe, I would like to thank you for sharing with us your valuable knowledge and time. So, for those of you who are joining for the first time to one of our webinars, this session will split mainly into parts. So during the first one, Dr. Kufer will present a slide deck and will guide us through the webinar topic. And this presentation will last around 35 to 40 minutes. And then in the second part, you will be able to make your questions live to the doctor. So there are basically two ways in which you can make your questions. The first method is pressing the raise hand icon in your webinar panel. So when it is your turn, I will unmute you and you will be able to make your question live by using your microphone. The second way, in case you prefer to do your question by writing, you can just type the question in the Q&A panel, and I will read it to Dr. Kufer when the Q&A turn arrives. So, without further ado, I thank you again for joining us today. And Dr. Kufer, the floor is yours, so you can start when you're ready.
Thank you, Alfonso. Hello to everyone. It's my great pleasure and privilege to be able to discuss with you today the essentials of diagnosis and treatment of lung cancer. The job you're doing as advocacy group is extremely important. There are major advantages in the diagnosis and treatment of lung cancer during the last years, and in lung cancer nowadays it's more and more important to have, of course, good academia, good scientists, good healthcare system, but of most it's important to have really dedicated advocates who will help to make all these new advantages true for most of the patients or all of the patients around the world, but certainly in Europe. Thank you very much for giving me this possibility. And my talk will be structured in a way that we will discuss everything, of course, general principles and major advantages in the epidemiology, screening, diagnostic, and treatment of cancer. Let us start with the epidemiology. Lung cancer is the most common cancer around the globe. More than 2 million people suffer from this disease every year, and it's also still the most frequent cause of death globally. The incidence of lung cancer is very high all over the globe, but just a moment, I'm sorry, next one. Yeah, it's working. The incidence is high all over the world, and in Europe particularly, it is extremely high, especially among the males. Also in females, the incidence in Europe and the northern part of America is high, and it is increasing. Here is the data from the Slovenian Cancer Registry. By the way, the Slovenian Cancer Registry is the oldest cancer register in Europe. It has been established already in 1950, and I'm really proud that we have such a wonderful registry. A registry is important for for good control of any cancer. Here you can see that the incidence of lung cancer in Slovenia among the males is slightly decreasing. Unfortunately, it is increasing among the women. And also mortality rates, which are decreasing among the males, are slightly increasing among the females, which is not a good news. This difference in the incidence comes from the fact that actually women started to smoke later than men in Slovenia and in the majority of the Europe. And that's why the majority of women started with the smoking after the Second World War. And that's why we are still seeing this increase. In men, the incidence is decreasing due to the slightly lower percentages of smokers among males during the last decade in Slovenia. We can also see that the survival rates, especially among women, are increasing, which is a good news. For decades, the survival rates for lung cancer were very dismal. We didn't have really effective treatment possibilities. It has been changed at the turning of the century, and it is changing now in a very positive way. And the first positive influence is seen especially among the females, because the females are the ones who have much more frequent so-called lung cancer with druggable targeted mutations, which are very important for effective targeted therapy. The most frequent ones are EGFR, ALK, and so on. That's the major reason why the survival is increasing, and also what is important is early diagnosis. Which are the major cornerstones for a good lung cancer control? Like for any cancer, we need effective prevention. When we are talking about a lung cancer, we really have in our hands a very, very effective prevention tool. This is a smoking cessation. You know about this very well, and I'm happy that in the majority of the European countries, in Slovenia already in 2007, even in our neighboring country, which is very developed and was also always the leader in everything, if you compare to Slovenia, in Austria, finally, 12 years after Slovenia, during the last months, the smoking ban has been adopted. So more and more countries have this smoking ban. Smoking cessation is really a very effective tool in primary prevention in lung cancer. We have also possibilities with lower occupational exposure and with decreased air pollution. All these measures could decrease the incidence of lung cancer. Of course, we will not abolish lung cancer. Still, people will suffer from lung cancer, but the incidence will be much, much lower if the world will quit with the smoking. And if we will be aware about the importance of the environment protection and air pollution decrease in the future. We have also a tool in secondary prevention screening. I will explain a little bit how far we are in the process of establishing a screening for lung cancer worldwide. Then very important cornerstone is early detection. For any cancer, it is very important to have early detection. It stands true also for lung cancer. Then one of the major improvements, personalized biomarker-driven treatment, which is much more effective than non-targeted therapies. And then access to treatment. You are patient advocates. I know that the LUCE is working very intensively in the field of the access to the diagnostic procedures and treatment in Europe, and we need to applaud LUCE and also other patient organizations and advocacy groups for all their efforts in this field. It's very important to have access to treatment. Without this, we cannot achieve improvement in survival, we cannot prolong survival and improve quality of life as well. And then last but not least, we need adequate supportive and palliative care for control of any cancer. Let us start with the prevention. As already told, tobacco control programs, anti-smoking educational programs, and of course smoking bans and cessation programs are the cornerstone of the very effective primary prevention we really have for lung cancer. There are not a lot of cancers for which we have such effective tools and so effective primary prevention. We only need to go in this direction and the results will be here. Then we already discussed about occupational exposure and air pollution. Secondary prevention, screening. A lot of work has been done during the last decade on the screening of lung cancer. There are some efforts with X-ray, then efforts to search for the malignant cells in sputum of the smokers. But unfortunately, all these, let's say, studies were negative. So nowadays, we have some promising results with blood tests. In the blood, with microRNA, there are some hints or some first signals that it might be possible in the future to detect in the blood, in microRNA, some changes that are actually the signs of the very early development of malignant disease in the human body. But these tests are not yet in the prime time. We cannot use them. But we have nowadays positive results from 2 trials which actually evaluated the value of so-called low-dose CT. It's very important with the CT to know that CT scans are associated with the exposure to the X-ray, and then that is why it is very important to decrease the dose that the patient received with the CT scan. And so that's why we are talking about low-dose CT. We have 2 trials. One trial, the first one, is the American trial. In this American trial, in which more than 50,000 smokers were included, 20% relative reduction in lung cancer mortality was found. So a substantial 20% relative reduction in lung cancer mortality was achieved with the so-called low-dose CT screening in the population of the smokers in the US. And there was already some signal that the effects could be, of this screening could be higher in the females. In large European Nelson trial, the results of which has recently been updated and published. The first results have been seen 1 year ago, I think, at the World Lung Cancer Conference. The colleagues presented these results. The reduced lung cancer mortality, reduction of lung cancer mortality was confirmed also in this trial among the European high-risk population of former or current smokers. The relative reduction in the mortality rate was even higher in European trials, and it was confirmed that the benefits of the screening are more obvious in females than in males. There is no straightforward explanation for this, but obviously the biology of lung cancer in females is a bit different, not only in non-smokers, but also in smokers. So we have positive results. The major question or the major challenges we are facing nowadays is how to make this screening cost effective, not only in terms of the financial cost effectiveness, but also in terms of the harms that could be done to the people who will attend this screening. Because with the screening, of course, the people can be exposed to unnecessary diagnostic procedures, which could be associated also with some morbidity. And that's why the major issue is to select or to make a consensus to find whom to screen. The higher is the bar, more we focus the selection of the patients, heavier smokers, younger people, the rate of, let's say, harm or unnecessary procedures will be lower. But again, we can miss this benefit for other people, other smokers. So the major question is whom to screen. Another question is how often to screen, how often to perform low dose CT screening. And then when we will have consensus about this, I'm sure that in very short period, European countries will embark on the screening of lung cancer. There are already some pilot projects running around Europe. I think that in England, they are very far in this preparation, and also in our neighboring country, Croatia, they are making huge efforts, and they have already made some important steps in establishing screening of lung cancer. What about the diagnosis of lung cancer? To establish the diagnosis in the patients with the symptoms, we need to act very quickly. We need to be vigilant. And here are the diagnostic procedures. Usually we start with chest X-ray. Sometimes already in the chest X-ray you can see such changes, but often it could happen that there are no major changes in the chest X-ray, so we perform, if the symptoms are still here, we perform CT. Usually we perform first CT scan of the thorax, and then we go to seek for a tissue to confirm that this tumor is malignant. Another policy is if the radiologists have a high suspicion that such a formation in the lung is a malignant tumor, we can already immediately embark on the CT of the abdomen and also CT of the CNS, because the metastases are most frequently seen in the abdomen or in the CNS. Then we have to collect the tissue. It's very important to have the tissue, and the pathologist need to tell us, okay, this is lung cancer, or this is some other, there is some other pathology. When we know that we are dealing with the lung cancer, PET-CT is mandatory for the patients. For him, according to the CT scan, we foresee, or we are talking about, so-called operable disease. We need to go for PET-CT because PET-CT sometimes can reveal small metastases that are not seen on the CT. PET-CT is not only a radiological procedure, it's also a kind of scintigraphy. There is a kind of immunomarker, and we don't see only a tumor, morphology of the tumor, but we can also measure the proliferation activity of the cells in this tumor. That's so-called SUV. And this SUV, if it is high, is very, very suspicious for cancer. And sometimes it could be increased also in inflammatory processes. But if it is very high, and if morphologically, then it is connected with the morphologically changes that are related to metastatic disease, then we are talking about the metastatic cancer. In patients with metastatic cancer and also in patients with locally advanced cancer, there is advice or highly recommended to perform MRI of CNS as well, because metastases in CNS are quite often seen in patients with lung cancer, and our decisions how to treat patients may be changed based on this important information. Then, based on this diagnostic procedure, we categorize or we define the anatomical stage of the disease. To make a story short, if anatomical stage or TNM stage of the disease of any cancer is actually categorizing the extent, anatomical spread of the cancer or anatomical stage of the disease based on the T stage. T means the volume of the tumor. The N stage, which means the how many nodes, regional or local regional, are affected, and based on a distant metastasis. And if the disease is only in the affected organ, that means here in the lung, and it's not too big, and only regional metastases are affected, then we are talking about operable disease. When we see by the radiological procedures the distant metastasis, we are talking about advanced metastatic disease, which is here in the red color. In between, we have disease that has spread to the local regional metastasis. Usually, these are mediastinal metastases and is not operable, but still potentially operable and curable. And we are talking about locally advanced disease in this scenario. Based on this anatomical stage, there are basic principles that when we are talking about operable stage, we perform surgery. If the patient does not have a major comorbidities, the first procedure is a radical surgery. The surgeons usually say we have removed all the cancer, we have destroyed all the cancer, and now you are cured. Then medical oncologists, we came and say, okay, perfect. On CT scan, on PET-CT, there is no tumor. The surgeons did a wonderful job. All the tumor masses were removed. But we know, unfortunately, that even after a radical surgical procedure, half of the patient relapse. And this relapse is due to the micrometastasis we cannot detect with our radiological procedures. We have effective systemic therapy, effective drugs that reach all the parts of the body, and we recommend systemic therapy. And the systemic therapy, namely chemotherapy for lung cancer at the time being, trials with targeted therapy and immunotherapy are ongoing. And I'm sure that in very, very near future, probably immunotherapy will also be a part of the adjuvant treatment, but for the time being, it's only in the studies. The standard treatment is adjuvant chemotherapy, and we advise to patients adjuvant chemotherapy, more or less to all patients, unless the patient has a very small tumor, less than 40 centimeters, and all the nodes are negative, then we don't advise it. But otherwise, we advise adjuvant systemic therapy. For locally advanced disease, usual recommendation is neoadjuvant systemic therapy. If the disease becomes operable, then we go to surgery. If eventually the disease is still not operable, technically is it not possible to remove the primary tumor and the metastasis, then we recommend so-called radical radiotherapy, of course, to achieve the radical control and the cure of the patient. In advanced metastatic disease, the major tool, very important tool, is systemic therapy. During the last decades, we didn't have a very effective therapies. Chemotherapy is effective, but not very effective. Far from the huge efficacy the chemotherapy is having in germline tumors, in lymphomas. In lung cancer, the efficacy of chemotherapy is limited. Only about 1/3 of patients have remission if they are in the metastatic stage. That's why it is very important nowadays to have novel therapies, targeted therapies, immunotherapies, which are much more effective, and targeted therapies also less toxic. So that's the major principle of the treatment. On the top of this, it's very important nowadays, or during the last 10 years, we know that it's not enough for effective treatment to have the information from our pathologists, whether we are talking about small cell lung cancer or non-small lung cancer. It's not enough in the non-small lung cancer to know whether it's squamous or adenocarcinoma. It's very important, especially in non-squamous. The majority of non-squamous cancers are adenocarcinomas. There is a very small part in which our pathologists cannot say whether it's adeno or squamous, and we are talking about so-called not otherwise specified morphology of cancer. But this not otherwise specified, we put in the same basket as adenocarcinomas. And for these patients, we know nowadays that these patients or these tumors with adenocarcinomas are very diverse in terms of their biology. These tumors sometimes are EGFR driven. They have a special genetic alterations, EGFR mutation, ALK rearrangement, RET rearrangements, or any of these very multiple genomic alterations which actually drive the cancer, which are behind the cancer and the ones to be responsible for the fast proliferation of the cells, for the metastasizing of the cells. And it's very important to know about this biological characterization of the non-squamous lung cancer nowadays, because these are targets and we have targeted therapies for these patients with these targets. So that's the major point about the diagnosis. We need anatomical stage, we need biology, and then we decide about the treatment. The prognosis of any individual patient depends very, very much on the fact whether the disease is diagnosed in so-called operable stage, which is till 2B, locally advanced or metastatic stage. And that is why so important is early diagnosis. We need to diagnose any cancer, and also, of course, lung cancer, as soon as possible. That is why it's so important to put the efforts. Of course, screening is important, and probably, or quite, I'm sure, that's my opinion, we will have screening in lung cancer as well, not only in breast or colon very soon. But even with the screening, even when we will have the screening, it's very important to establish in any country all the formal procedures to enable any patient with the symptoms. Screening is for the patient without the symptoms. We are searching for very small changes, very small tumors that are not producing any symptoms. It's very important to have early screening for the patient with the symptoms, because if the patient is diagnosed in early stage, the prognosis is much better, the possibilities of cure are much higher. In Slovenia, unfortunately, but I'm quite sure that the most or less, when I'm talking with my colleagues around not only Eastern, also Western Europe, there are problems with the early diagnosis. In Slovenia, according to our hospital registry of My Clinic Golnik, at which half of the Slovenian population, of the whole population of lung cancer patients are diagnosed, so our data are very reliable for the whole population of Slovenia, half of the patients, the waiting time from the first symptom to the, not to the diagnosis, but to the referral to our diagnostic department is between 1 and 3 months. And for 1/4 of the patients, namely 23% of the patients, it is more than 3 months. It is too long. It is extremely too long. We are working on different, let's say, procedures or different guidelines how to decrease this lag time between the first symptom and the diagnosis, because early diagnosis is really extremely important as any screening in any cancer, not only lung cancer. So this is about epidemiology, diagnostic, the cornerstones in these fields. What about the treatment? We have already discussed, we have these algorithms, we have guidelines, how to treat operable, locally advanced, and how to treat metastatic disease. But what are the major advances? What are the hints we need to be very careful about to establish these new procedures and to get access to novel treatments in our societies to achieve better survival, to achieve better quality of life? Of course, we are talking about lung cancer. I will stick mainly to non-small cell lung cancer. Unfortunately, in small cell lung cancer, there are no major advances during the last few years. I'm sorry for this rumor. I will just close the window. Sorry. Sorry for this interruption. Major advances during the last decades have been made in the field of the non-small cell lung cancer. So in the small cell, some advances with the immunotherapy during the last years. And what is very important to point out is that with early diagnosis, we are seeing also operable small cell lung cancer. At my institution, each year we have around 10 patients that came to us with a small cell lung cancer in the operable early stage. We are very happy for these patients. They have a surgery, they have radical surgery, and nowadays, even 20 years ago, there was actually the belief that small cell lung cancer patients should not have a surgery. Nowadays, if we are talking about the operable disease, of course, these patients are referred to the surgeons and have radical surgery, which is advances in our approach. What about other advances or the major advances in non-small cell lung cancer? What is very important is that nowadays the patients can be spared for large surgical procedures and thoracotomy in the majority of patients. The so-called video-assisted thoracic surgery can be used. And actually, this video-assisted thoracic surgery outperforms thoracotomy. We were a little bit concerned about whether the survival rate of the patients will be the same, whether the cure rate, which is most important, will be the same. It's completely the same with the VATS compared to the thoracotomy. Here are the results of the first trial published only in 2009. We have additional confirming trials. So nowadays, the approach is to go for VATS if it is possible. The morbidity, post-operative morbidity is lower. There are less complications after the VATS compared to the thoracotomy. So it's the standard procedure. Another important advantage is that we have learned that also in lung cancer, not only in breast cancer or colon cancer, there are some patients that have only oligometastatic disease. What is oligometastatic disease? We are still talking about EORTC. We have now EORTC consensus paper and also a large paper of the joint paper of joint organizations dealing with lung cancer with some proposals which what kind of disease in lung cancer can be classified as oligometastatic disease. The general rules nowadays are less than 3 metastases in less or not more than 2 organs. And for patients with oligometastatic disease, we have data. Here are the data of the most important prospective trial showing that patient receiving, in addition to standard treatment, radical local therapy, this is the blue line, have a much better survival. Radical local therapy and therapy, the removal of the oligometastatic sites or tumors, either by surgery or radical radiotherapy, are associated with much higher survival, and we hope that some of these patients are also cured. So it's very important. If, according to the PET-CT, you have oligometastatic disease, then the patient should discuss with her doctor about a possibility of so-called radical local therapy of the primary tumor and all oligometastatic sites. Also, if the metastases are in the CNS, in the central nervous system, if they are oligometastatic, nowadays it is a recommendation to surgically remove it or to use so-called stereotactic radiotherapy. Stereotactic radiotherapy is a major advance in the radiotherapy of CNS metastases, but it is also used nowadays for small tumors in the lung. If the tumor is small, you can perform also in very small tumors in the lung stereotactic radiotherapy, which is, according to the first results, equally effective as surgery. And in the CNS system, the stereotactic radiotherapy of oligometastasis up to 3 or 5, some centers say 5, some centers 3, is also a radical treatment and equally effective as the surgery of the metastasis of the CNS. What about the systemic treatment? In the systemic treatment, the major advances we have already discussed have been made in the targeted therapy. For patients with the targets, namely EGFR mutation, ALK rearrangement, ROS1 rearrangement, or BRAF mutation, we nowadays have a very effective targeted therapies. And that's why the determination of this testing for these 4 alterations is mandatory according to the European and according to the American guidelines. The testing, you know very well, or your organization, again, Luce organization, performed a survey about the testing. The results of the survey a few years ago were not so positive. It is improving. More and more countries, also Central European countries, are testing for these 4 gene alterations. They are not mutations, all of them. And then patients get a standard therapy. There are much more alterations, plethora of these molecular subtypes or molecular factors that can be determined by the procedures of molecular biology, and there are a lot of drugs in the development for other targets as well, like RET and TRAC, and a lot of these drugs are very, very far in development, already submitted to EMA, and I'm sure that especially for RET and NTRK alterations, these drugs will very soon will be registered by EMA. One NTRK targeted drug is already registered by EMA, and it will be available to our patients very soon. For the time being, this is the list of the alterations that should be determined and the drugs that are recommended by European Society of Medical Oncology. So that is something we should put in our guidelines and our approaches how to treat patients in European countries. Based on the targeted therapy, the prognosis of the patients with lung cancer has improved substantially. Here are the data, real-world data from the observational trials from France and other countries, showing that with the sequential use of different ALK-directed drugs, the median survival of the patients with a metastatic, not operable or locally advanced ALK-positive patient in a routine clinical practice can be extended to 7 years. Major improvement. This is more that we can achieve nowadays with the HER2 targeted therapy in breast cancer, which is the first truly remarkable breakthrough in the targeted therapy of any cancer in the last 2 decades. So major improvements. The problem we need to solve, or the challenge, is that to any targeted therapy, if the disease is already metastatic when we diagnose the disease, these drugs does not mean the cure. Sooner or later, always the patients encounter resistance to particular drug. That is why it's very important to have different sequential possibilities. not only one drug, multiple drugs on the table to use in the patient. To wisely use these drugs in the sequence, we need to have information about the molecular biology of the tumor. The molecular biology of the tumor is not fixed. Tumors are very wise, they're very bright. They change the molecular biology. They adapt to the treatment. And when the patient is receiving one ALK or EGFR TKI, some other mutations or some other alterations happen. In EGFR mutated patient, the most often it is T790 mutation after first, second generation. In ALK positive patients, there are multiple ALK mutations or some other molecular alterations we can determine in the rebiopsy tissue or even in the blood. And based on this new molecular profile, we can select the proper second, third, fourth, hopefully fifth-line targeted therapy. Liquid biopsy is a very important step forward in this precision medicine, because sometimes it's not easy to rebiopsy the tissue. It's quite demanding for patients. Not all patients are in a condition or have some comorbidities, so rebiopsy could be a challenge. That's why it's very important to have the possibility of determining these new alterations in the blood. Blood is much easier to obtain, is minimally invasive procedure, allows for this monitoring. And for testing of T790 mutation in EGFR positive patients is already a standard, and it is a part of the routine procedure. Here you have the schema. If you have the progression of the patient on first, second generation, we go for T790 mutation. Of course, nowadays we have osimertinib that can be used upfront. After osimertinib, we don't see T790 mutations. We see multiple other alterations, and nowadays we have a lot of data telling us that in very, very near future, it will be possible in the blood to detect these multiple alterations. It's possible already nowadays. There are different NGS platforms. Some of them, like Foundation One, has already FDA, let's say, approval. But still, we need some time to really see which is the best method to determine in liquid biopsy different alterations. But it's certainly a way to go forward. Just a few words at the end about the immunotherapy, major advances in the immunotherapy. For long years, we were devastatingly trying to find drugs that will stimulate immune response to the cancer cells. There were a lot of disappointing stories and trials. And sometimes we already thought that there will not be any possibility to really kill the cancer cells by our immune system. The major breakthrough came a few years ago, and two of the researchers already get the Nobel Prize for their research in the field of the immunotherapy of cancer. This new story is built on the very, very simple story. All our major improvements are always based on a simple story. When you know what is the hint, then everything is simple. So what we are talking about. On the lymphocytes, which are our immune cells, and which attack not only bacteria and viruses, they attack also the tumor cells. The tumor cells have antigens, have some properties that are recognized by T lymphocytes as some foreign, let's say, antigens or something not familiar to our immune system. But these immune cells, T cells, have some breaks, some inhibitory signals on them, which prevent these cells to act against the cancer, and to prevent these cells also to act against our normal cells. because we need to find a balance not to have autoimmune diseases during our life. That is why we need these receptors, which are actually inhibitory receptors that block the T lymphocytes. And the drugs, which are called checkpoint inhibitors, and here have the list, you have the list of these drugs. These inhibitors are directed against the PD-1 or PD-L1 inhibitor or CTLA-4 inhibitor on the T cells or other immune cells. These drugs block these inhibitory signals, and the T cells are still again active, and they act against the tumor cells. The hypothesis was that the immune therapy will be most effective in the patients or in the tumors that have the tumors with a high mutational burden. And the lung cancer, non-smoking lung cancer without targetable mutations, is a cancer with a high level of mutations. So our expectation was that these checkpoint inhibitors will have a high efficacy in lung cancer. And it turned out to be true. The immunotherapy with only one monoclonal antibody in heavily pretreated patients, it is not first line, resulted in the 20 years, 5-year survival, which is very, very positive result and very encouraging result. And if we use monotherapy, here are the results with the pembrolizumab in the upfront first-line therapy in patients with lung cancer with so-called highly expressive PD-L1. This PD-L1 inhibitory receptors need to be expressed to make immunotherapy effective. It is not a predictive marker, but it's an enrichment marker. Patients with a high expression respond better to immunotherapy than patients with lower expression of PD-L1. There are still a lot of concerns. What is the best method to determine, how to determine that's a heterogeneity of tissue. But anyhow, if the PD-L1 is highly positive and you treat the patient only with the monoimmunotherapy, very positive results. After 2 years, half of the patients are alive and they don't have a relapse of disease. Hopefully, we'll see in the future they are cured. Only monotherapy. With a combination of the immunotherapy and chemotherapy, this treatment is even more effective. And in patients with less than 50% of the PD-L1 expression, in these patients, the combination is extremely important as well. And probably that's the cohort of the patients for which we will use or we recommend nowadays the combination chemo plus immuno. Again, high rate, half of the patients are alive without a relapse, without the problems after 2 years if we use immuno plus chemo combination. Combination is also very effective if we combine immunotherapy with radiotherapy, not only chemotherapy. Radiotherapy sensitizes to the effects of the immunotherapy. And with durvalumab, after concurrent chemoradiotherapy in locally advanced cancer, non-small cell lung cancer, again, we had very positive results from the Pacific trial. Patients which received after radical radiotherapy durvalumab for 1 year had the much better survival. The hazard ratio was the rate or the risk of the death was decreased by 32%. And again, after 2 years, 70% of the patients without relapse and without problems. And hopefully it's again the cure. Just a case, we are a little bit late. I will try to be very short. Case of, this is one of my patients which was diagnosed with the advanced non-small cell lung cancer, all markers, EGFR, ALK, ROS1, BRAF negative, unfortunately. At that time, I said to the patient, I don't have very good news. Unfortunately, there are no targets. We don't have targeted therapy. but we have a high positivity of PD-L1, and I'm happy that I can offer you a new therapy, immunotherapy. The patient received pembrolizumab monotherapy. That happened 2 years ago. After 3 months, patient had no symptoms anymore, no pain in the shoulder, minimal toxicity, performance status was 2, and as you can see by the PET-CT scan, I'm sure that all of you can recognize these enlarged positive lymph nodes in the mediastinum, in the axilla, on the neck, in the neck left. All these nodes disappeared after only 3 months of treatment. Nowadays, 1 month ago, we finished with the treatment. After 2 years, the patient is in complete remission without any symptoms, without any problems, and we all hope he is cured. So immunotherapy is a big hope. It is now in the guidelines for the majority of the patients without targetable mutations. We recommend, according to the ESMO, immunotherapy in patients with high expression of PD-L1. Monotherapy should be considered, monoimmunotherapy without chemo for patients with less than 50% PD-L1 expression combination. It stands the same for squamous cell carcinoma, again the same story. So there are major challenges in front of us, how to even improve the effect of the immunotherapy. Should we use it always in the combination with chemo, or maybe in the sequence after chemotherapy, whether to use it with radiotherapy in locally advanced already from the upfront with the combination, or should we stick to the policy we had in the Pacific trial, first radio and then immunotherapy? Then there is still a big question how to better select patients that will respond to therapy. PD-L1 is not a good marker, it's enrichment, not predictive marker. Then there is a question of the duration of the therapy. So far we have data that 2 years is better than 1 year. That's why my patient received 2 years. We have no data but longer duration, and probably we will need to learn a lot about this. Then also how to better control the adverse effects. Adverse effects do happen with immunotherapy. We have learned a lot how to recognize them, how to detect them early, how to cope with these side effects, but still there is a long way to learn about this. So that's really, like Professor Zelinsky always said, this is just the beginning of the very long friendship, and long way is in front of us to optimize immunotherapy. Last but not least, palliative care is important. Even though we have major improvements, more and more patients are cured, we need palliative care. A good palliative care improves survival and most of all improves quality of life. And what is also important, not only palliative care, supportive care is important. To really execute and to enable patients to receive effective targeted immunochemotherapy, we need to support patients with a good supportive care. Here it's very important to have a good team, nurses who are on the phone, who can advise the patient, who can lead the patient through this supportive care and advise them about the preventive measures, and also if we have side effects, how to cope with them. The future is in so-called patient-reported outcomes, in the connection with the patients through new web-based platforms, on which nurses will detect these side effects or the problems or the symptoms, and if the symptoms are defective and we cope with the symptoms continuously, not only every 3 weeks, which are the usual time periods in which oncology sees the patient, the survival is much better. So thank you very much. I'm sorry we have only 10 minutes, but hope for a nice discussion during these 10 minutes.
Thank you very much, Dr. Kufer. I think I speak on behalf of our audience that this has been a very comprehensive, a very clear presentation. And I take one of your last messages of hope, which is the fact that thanks to all these new advances in treatment and diagnosis of lung cancer, we are progressively winning this battle against lung cancer, and yeah, there is still a lot of way to walk. But as you said, like Rick said to Luis, this seems to be the beginning of a beautiful relationship between these new treatments and the way to improve the lives of people diagnosed with lung cancer. So we have some time for questions. I have received some from all of you by writing, but just to remind you that if you would like to make your questions live, just press the raise hand button. I will unmute your microphone. So I'm going to start with the first question, which is, at the light of the results of the Nelson and NLST trials, do you find realistic that we will see a more systematic implementation of screening programs in high-risk populations throughout Europe?
Mm-hmm. Yes, as I already said, nowadays, 2 years ago, when we had only American trial, I had some doubts. But with the European trial, confirmatory results, it is quite clear. And there is a lot of work done now on in the field of artificial intelligence. It's very important nowadays to have a clear criteria how to select the changes seen into CT scan for further diagnostic. That's the major issue. And with the measures of artificial intelligence, we will be able or will enable us to better characterize these changes on CT scans based on the learning of artificial intelligence, which changes are really that does mean the highly suspicious lesion, and for which lesions we will need to proceed with the diagnostic. Because the major question is, if you go for CT, there are always some changes. And if we will biopsy all these changes, we will not make a lot of benefit for the patients and for the society. But there are now major improvements in this terms of artificial intelligence, how to select these changes that need to further diagnostic. And when we will have this, I think that will be the major step. And of course, we will need to make some, let's say, decision on which smokers to screen.
Thank you very much for that clear answer, Dr. Kufer. We have another question from one of the person from the audience regarding screening. He's asking, is there any finding which explains why women takes more advantage in lesser mortality rates when going through low-dose CT screening compared to men?
I'm not aware of any firm explanation. People are thinking about these results, going deeper in the results. I was not so much I'm a medical oncologist. I'm involved in the treatment. I was not so much involved in the screening. Maybe there are some information I missed, but I'm not sure that there are any clear data. Maybe one hint is that among the women, when you diagnose the disease, we are seeing much more ALK, EGFR, or other genetic alterations that are molecular drivers and could be attacked with drugs. Not only among non-smokers. Of course, these alterations are more often about non-smokers, and because the population of females with lung cancer is a larger proportion of non-smokers, but also among the smokers, there is in the female population a larger population of the patients with druggable mutations. That's one explanation. Another explanation could be that even if you have with the screening detected change or tumor lesion that should go in further diagnostic, maybe women are always more keen to stick to further instructions of the doctors and the team how to proceed and how to go to the final step of the diagnostic and further procedures.
Thank you so much. So there is another question. This has to be with the testing part. So the person is asking, what happens when a patient has a mutation in which a drug is not available, like for example in KRAS mutation? Should patients be tested anyways? And he also says, I have heard something about panel genetic testing to have a genetic profile of each patient, but I don't understand it quite well. Could you provide more information on this?
Yeah, it's always, a glass is always half full. Regarding the KRAS mutation, we had a long discussions, and also at my clinic, University Clinic Golnik, our pathologist said, no, I will go for KRAS mutation. Right? We said, why? It's a waste of money. We don't have, it is a mutation, but we don't have any drugs. A lot of trials were negative. And so we said, why? But during the last year and during the last World Lung Cancer Conference, we had the presentation of some new drug. It is very promising drug that is effective in a specific KRAS mutation, KRAS 12G mutation, which is half of all KRAS mutations. So the story is, to make the story short, certainly we need to test all the patients for the targets for which we have drugs on our table. That also means in the countries which unfortunately maybe still don't have BRAF drugs, BRAF-directed drugs, why to do testing for BRAF mutation? We need to test only for the mutations or alterations for which we have drugs. But the situation can change in 1 week, in one, maybe not week, in 1 month. We can get some new drugs. And it's very wise, if you have enough tissue, to test for more alterations. Maybe the patient will need this information in 1 month or 1 year. It's not always possible to do rebiopsy.
Understood then. So we still have 3 more questions. The next one comes from a patient. It's a particular case, and she asked, after 4 years on TKIs, erlotinib and osimertinib, I develop a HER2 amplification. She has been offered to take part in a trial in the Netherlands with TDM1, that is trastuzumab plus emtansine, to attack HER2, and osimertinib for EGFR exon 19 deletion and T790M. What are your thoughts about these trials, and do you have any other suggestions or information about it?
The first remark is that it's a very good news that you have possibility to participate in clinical trials, because after relapse on osimertinib as second line, there is no standard possibility of targeted or therapy. There are some data about the efficacy of chemoimmunotherapy from one IMpower trial, but immunotherapy in patients with targetable mutations is not very effective. So very important that you have a possibility. If I understood well, now you accounted the HER2 mutation.
Amplification. Yeah.
HER2, yeah. And you have been offered the TDM1 plus?
Plus osimertinib for the EGFR exon 19 deletion and T790M. Yeah, so it would be trastuzumab, emtansine, and osimertinib. Yeah.
Yeah. I think that's a very, very reasonable design of this trial. And I would certainly recommend you. You are very lucky that you have a possibility to participate in the trial.
I think
both these mutations are druggable mutations. We don't have drugs on the table that are proven to be positive in HER2 mutations in lung cancer, but for TDM1 there are some positive results, and there are also results showing that even if you have a new genetic alteration like HER2, it is wise or reasonable to structure the trial in a way to keep with the EGFR blockade. And osimertinib is still blockading the cells that are still EGFR driven. So a very good combination that's my personal opinion, and I would certainly advise you to take part in the trial.
Thanks a lot, Dr. Kufa. So there's still two questions left. The next one is related with the blood microRNA that you mentioned before, and the patient is asking when the future blood microRNA will be possible and greatly used in lung cancer.
Yeah, we are talking about two things. Blood microRNA is a little bit different procedure than that is PCR or for detecting genetic alterations in the circulating DNA. Blood microRNA is a wider, is tested for screening of cancer. That's the method that actually detects very few cells or very few DNA material in the blood, and now it is tested whether it could be used for a screening. Another issue, that's not the standard, we will see in the future. Another issue is the liquid biopsy. That means that in the blood of the patient with the already confirmed lung cancer, during the treatment, we take the blood, there are cells in the blood, cancer cells, and in the DNA of these cancer cells, we are detecting the new mutations or alterations that had happened during the particular treatment. And for this liquid biopsy, as I told you, T719 is a standard, routine, recommended, a must. We should do it. But there are different NGS procedures available for the testing of multiple other alterations that happen during the treatment, like we discussed, HER2 alteration, MET is important. This is already available and we can use it, or we should use it.
Okay, thank you very much. So we go with the last question that I have received. And it says, are there any relevant advances in small cell lung cancer discovered recently? And how does the future look like for patients diagnosed with this subtype of lung cancer?
Small cell lung cancer is still a dismal story, to be honest, but there are advances. There are advances for extended disease, let us say so. Locally operable disease is very rare, like I mentioned, but the major advances is that we are not telling the patient we can't do anything except chemotherapy. If it is operable, still we do operate, we do surgery, and there is a possibility of cure. For locally advanced is still radiochemotherapy. The trials with immunotherapy in locally advanced small cell lung cancer are ongoing, and based on the positive results with the immunotherapy in the advanced small cell lung cancer or extended small cell lung cancer, we also have positive results with the combination of chemo-immuno. I showed you the positive results of combination of chemo-immuno in non-small. It's the same in small cell. We have two trials, one with atezolizumab IMpower trial and one with another checkpoint inhibitor, durvalumab Caspian trial, showing a substantial, significant, statistically significant improvement in overall survival in patients with extended small cell lung cancer, in which treated with combination of chemo plus immuno compared to chemotherapy alone. Unfortunately, the results of 1 year survival, of 2 years, are not so good like in non-small cell lung cancer. We are not talking about 1 year with about the half of patients being about the symptom, hopefully cured, but still there are positive results and a lot of trials are ongoing. Immunotherapy is a major advance in small cell as well for advanced disease.
Well, so thanks for this answer. And we have run out of time. Indeed, we have gone 10 minutes beyond what was expected. So I really would like to thank you again for your time, for your very clear and very, very interesting presentation, I have to say. And I think I really speak on behalf of our audience. And yeah, I would really like to thank you on behalf of Luce for being with us today. for our audience, for all of you who has attended this webinar, I hope you find it fruitful. And just to remind you that the full content has been recorded and will be available at the Luce website in the upcoming days. I also strongly recommend you to stay connected to our social media channels, Facebook and Twitter, to receive the last updates on the activities and projects that Luce is developing. And I just would like to give you again thanks for attending. We stay in touch, and we hope to see you in online in our next webinar. So I would like just to close this session and wish you all a very fruitful evening, a very nice evening. And once again, Dr. Kucher, thank you very much for being with us today.
Thank you very much. It was my pleasure.